The AANA is pleased to present the Wellness and Chemical Dependency in the Nurse Anesthesia Profession curriculum to increase awareness and knowledge of the need for each of you to be healthy and well. Many of you are viewing this curriculum as nurse anesthesia students. We're excited to have you begin this fulfilling profession. We believe it is imperative that you learn about occupational risk for addiction at this early stage of your anesthesia education. Equally important is for you to discover the need to adopt and employ healthy lifestyle behaviors throughout your professional tenure. Some of you are further into your careers and may personally know colleagues who have suffered the consequences of turning to unhealthy habits, such as drugs or alcohol, to cope with personal or professional stress. Whatever your career stage, professional lifestyles that promote effective coping, adaptation, and resilience can be taught, learned, and adopted. These modules provide a number of simple but essential elements to forge a long and healthy career. The overarching goal is to create a healthier workforce and, as a consequence, to optimize patient safety. The curriculum is presented in 6 modules. Each can be viewed independently by the learner at any time. Module 1 and 2 introduces general concepts and the dimensions of wellness, the threat of stress, and the need for resilience. Module 2 explores specific stress research data from the CRNA and student nurse anesthetist populations. Module 3 expands on these concepts, addressing specific healthcare stressors, and introduces the risks for chemical dependency and addiction. Module 4 imparts a broad overview of the disease of addiction, along with the signs and behaviors to recognize an impaired colleague. It also presents an introduction to understanding of mental health conditions, such as burnout and depression, and the impact of these on overall well-being. Module 5 speaks further to the consequences of the disease of addiction, introduces treatment and recovery, explores the challenge of potential reentry to the profession, as well as relapse. Module 6 highlights the concepts from the first 5 modules and offers resources for creating and sustaining a personal wellness plan. We hope that this curriculum introduces each of you to the concept of building your personal wellness arsenal of coping skills and resiliency strategies. The learning will facilitate the development of a healthy approach to stress reduction throughout your life. Finally, it will focus on the elements of sustaining healthy relationships, diet, exercise, and carving out adequate time for recreation as well as sleep and restoration. With knowledge as power, we envision that the increased awareness brought about by engaging with this module series will help reduce the incidence of substance abuse by CRNAs and student nurse anesthetists. It is further hoped that this knowledge may also prevent the threat of untimely death related to substance abuse in the anesthesia provider population. An impaired provider poses great threat not only to themselves, but also to the patients in their care. We encourage nurse anesthesia educational programs to advance wellness and chemical dependency education during the student orientation and inculcate these principles throughout the program. The goal is to strengthen knowledge and coping skills and proactively seek balance to avoid professional and personal vulnerabilities. The AANA thanks the Curriculum Task Force volunteers who contribute to the content of these modules.
Module 4 is titled Risk and Exposure: The Signs, Symptoms, Pathophysiology, and Comorbidities of Substance Abuse. The purpose of Module 4 is to introduce professionals to the concepts of the roles of DNA, family history, environment, and cultural events that influence you and your behaviors as a person. There will also be a brief discussion of signs and symptoms and the pathophysiology and comorbidities that accompany depression and substance abuse. The objective of this module is to introduce the learner to the causes, signs, and symptoms, irreversible psychological and physiological damage, and treatment opportunities of substance abuse. There are current and alarming research results regarding CRNAs and addiction. The facts are, Clark and Stone in 2000 reported 1 in 10, or about 10% of CRNAs, become addicted, and these are the cases that are reported. What about those addicted CRNAs who are not reported? What about those CRNAs who misuse drugs? What about those CRNAs who have other addictions or mental health disorders? It is estimated the final numbers of those CRNAs with severe to moderate mental health issues may be in the 20 to 25% range. Berry, in 2001, reports that about 16% of the population self-reported drugs and alcohol. Because professionals are concerned about losing their license, many go unreported. Bell et al. In 1999 further defines the population as male and practicing for 6 to 10 years. Clark and Stone also report that these are very intelligent healthcare providers. We need to do a better job and not only help our fellow students and coworkers, but also open a dialogue based on the facts and really take a look at why this is a problem in our profession. If the right factor and/or stressor, or a combination of factors and/or stressors, affects one at a critical time in their life, the individual may be more inclined to develop an addiction. There are a number of addictions that can arise, including alcohol, heroin, gambling, sex, computer, eating, or other process addictions. Drug misuse is the most common and the most deadly behavior that can be chosen by a healthcare professional. Nurse anesthetists feel they have a good command of pharmacology and physiology and can therefore control the effects of drugs even when they personally take them. Unfortunately, susceptibility combined with compulsive behaviors leads one to addiction, many times without control. The best course to take is to make the choice not to use, misuse, or abuse drugs. Only use drugs as prescribed by your healthcare provider. Bell et al. Ranked the most misused drugs in this order. First, opioids. Second, benzodiazepines. Third, nitrous oxide. Fourth, propofol, followed by dissociative drugs, agonist-antagonist, and lastly, barbiturates. Each addict does not usually use or misuse just one drug. Alcohol, because it's more readily available, is generally a substitute until the primary drug can be obtained. This leads the nurse anesthetist to polypharmacy when one or more preferred substances are not available. Propofol, also known in recent years as the Michael Jackson drug, has become a drug of abuse as well. The standard dose of propofol is 2 to 2.5 milligrams per kilogram body weight for the induction of anesthesia within 1 to 2 minutes and arousal after 5 to 10 minutes. After a bolus injection, patients lose consciousness at small blood concentrations and regain consciousness through fast redistribution as concentrations rapidly fall. The onset of unconsciousness and CNS depression are also known to be related to the speed of injection. The mechanism of action is not completely known. However, the drug probably exerts its pharmacological effects by enhancing the function of the GABA-activated chloride channel. In the CNS, propofol produces euphoric feelings, sexual hallucinations, and has sedative and relaxing effects. Propofol's euphoric effects are clinically known and have also been demonstrated in a double-blind randomized study by Wishmeyer et al. In healthy volunteers using propofol in sub-anesthetic dosages. The authors of this study concluded that the use of propofol may be rewarding in some people without a history of drug abuse. Dancing with the White Rabbit is an imaginative view of those who have experienced the effects of propofol and likened it to an adventure with Alice in Wonderland. In a 2008 California Society of Anesthesiologists Bulletin article titled Dancing with the White Rabbit, Dr. C.F. Ward wrote about propofol's effects. As someone who initially was trained with pentothal, as the induction agent of choice, propofol represented a significant change in my practice. I even remember my first experience using propofol. A young woman who was emerging from a MAC anesthesia looked at me as though I were a masked Brad Pitt and told me that she felt simply wonderful. This bore no resemblance to my experience with other sedation agents, and I felt then that this might become an issue of concern for propofol. A feeling of euphoria with no residual hangover might suggest propofol is a near-perfect mood-altering drug, but it is one that possesses an extremely thin window separating the dreamy state from the non-responsive respiratory arrest. Healthcare providers must be alert for current and future drugs that may be abused by their colleagues. Dr. Bell's 2007 research on the current state of drug misuse by CRNAs found that 3 factors contribute to drug misuse. The practice of anesthesia is unique and allows access to drugs in large quantities. This, in addition to the thought that CRNAs are able to control the pharmacology of the readily available drugs, even when self-administered, is an optimistic and deadly combination. In some practice settings, the lack of accountability also contributes to the use, misuse, and abuse of drugs. Genetics, stress, fatigue, burnout, and other vulnerabilities of health providers lead CRNAs and students to choose drug misuse and abuse or other addictions. Therefore, wellness and the promotion of wellness at work is essential to good health and drug prevention. Oftentimes, there are factors outside of the workplace that contribute to these vulnerabilities. While family and friends can be a very important source of support during hard times, adversely, family and friends many times contribute to addiction by becoming enablers. Enablers help provide a source of drugs, protect the individual from discovery, sometimes for selfish reasons, and provide the financial and social support for the addict. Even children of the addict provide a veil of protection for an addicted parent. Substance abuse disorders are the principal cause of impairment for nurse anesthetists. The characteristics of addiction lead to a catastrophic chain of events for practitioners. They often end up harming themselves, their family, and potentially patients in their care, as well as their career. The loss of control over substance use leads to overuse, intoxication, addictions, and withdrawal. This leads to poor occupational functioning, poor clinical outcomes, the inability to practice safely, and causes potential harm to patients. In order to combat addiction, we must first understand it. Addiction is the transition to a progressive, chronic, and relapsing state that begins with the euphoric effects of these potent intoxicants on primitive reward systems that underpin basic biological survival drives. In short, an addict will run risks and many times do anything to fulfill their compulsion. Hence, people get DUIs, spread hepatitis and other diseases, face financial ruin, and are shunned from family and society during their addiction illness. The spiral effects of addiction require emotional and physiological adaptations that eventually lead to death. To the addict, the initial reward is feeling good from taking the drug. As the drug is used more, tolerance leads to more use to obtain the same initial feeling, leading to even more drug use. The volume of drug use becomes such that the same initial feeling cannot be obtained regardless of the amount of drug consumed. Additionally, there is withdrawal that occurs when not taking the drug, and larger quantities of drug become necessary to satisfy the physiologic craving. The craving becomes so overwhelming that individuals risk financial, social, and personal demise to obtain the drug. The initial thought that addiction was a disease was originally developed by Dr. Benjamin Rush in the late 1700s and gained scientific credence in 1960 with Jelinek's disease concept of alcoholism. The disease model has even to this day served to better treat addicts. Originally, the disease of addiction was rejected by the American Medical Association until the 1980s. Now addiction is considered a disease, and the AMA has accepted the framework for Alcoholics Anonymous and other programs that have made a difference in the lives of addicts. The initial acceptance was supported by significant research that was produced from a variety of research projects. This past decade has seen further strides in understanding addiction and dependence through the tremendous amount of research on the subject. Clearer understanding and specific definitions have been sought while employing a deep-rooted framework in neurobiology. What was once considered a disease of personality disorder or a lack of will and/or dysregulated emotional states containing uncontrolled coping mechanisms has now been shown to have a pathogenesis founded in neuronal pathways, hyperplasticity of reward centers in the cerebral cortex, and neurotransmitter-mediated messenger pathways, which render the addict a prisoner to his or her own neurobiology. People know they are addicted but can't stop. They know they need help, but fear the loss of drugs, as well as the profession, financial, and law-breaking repercussions. Put simply, drug and alcohol dependence is impaired control over drugs and alcohol use. It is probably caused by a dysfunction in the brain's pleasure pathway. Substance-related disorders are characterized by chronic use and progression that threatens wellness. Addiction changes brain circuitry, making it hard to apply the brakes to detrimental behaviors. These brain modifications are known as changes in neuroplasticity. Addiction transitions to a chronic disease when neuroplasticity is changed. Neurologic changes in the brain provide a drive to continue certain behaviors for survival. Addiction begins with seeking pleasure or relieving pain. The brain is programmed normally to seek pleasure in sex and reproduction, eating, etc. Chemicals alter that sensation so that pleasure must be sought continuously, and there is an inability to achieve salience. Withdrawal of chemicals from an addict is dangerous in that it can produce a powerful sympathetic overload, leading to catastrophic physiologic changes. It is important to get help before these changes take place. It is common for colleagues to overlook many of the signs and symptoms of addiction for a number of reasons. First, we do not expect our colleagues to take drugs. Second, we may deny the fact that our colleagues are taking drugs because we do not want them to get in trouble. Third, we just don't want to get involved. Fourth, we may just ignore the situation in hopes that someone else will take care of the issue. It is our professional responsibility to our patients, our colleagues, our profession, and ourselves to report any drug misuse or abuse. In some states, nurse practice laws can prosecute nurses who observe and know about an addicted colleague but fail to report it. Let's look at this further, because recognizing abuse, whether it be coworkers, friends, or family, can be difficult. It's of life and death importance throughout your career that you have an understanding of the basic and consistent behaviors that are often seen in an impaired anesthesia professional. Often it's out-of-control behavior, such as intoxication or wide mood swings, such as alternating between mania and depression. Also seen can be isolation, problems with authority, both in or outside of the hospital, and overreactive behavior when questioned or criticized. Another indicator is taking extra cases and/or call, which indicates the desire to always want to be around the OR environment, even when not scheduled. Yet, in contrast, there are frequent breaks taken to go to the bathroom or just disappearing altogether when on duty. Anesthesia records can show sloppiness or unexplained problems with the documentation, such as the patient's pain in the PACU is out of proportion with the recorded amount of drug administered. There can also be a gradual decline in work performance and poor hygiene. Other observable signs include dilated or constricted pupils, wearing long sleeves regardless of the temperature, alcohol on the breath, or the overuse of cover-up odors such as perfume or mouthwash. In anesthesia professionals, the first observable symptom of substance abuse has been known to be finding a colleague dead or comatose in the bathroom or call room from an accidental or intended overdose. This is different than addiction symptoms seen in the general public because of the availability and rapid dependence that occurs following abuse of anesthesia drugs. If you can't remember all of the exact signs and symptoms of substance abuse, just remember these 4 A's. Attitude. Are they behaving strangely around those in authority? Or are their work habits changing? Like we mentioned, taking more call or sloppy charting. Affect. Meaning, are they isolated from others or demonstrating wide swings in their moods? Attendance refers to their workplace behaviors. Are they often missing when on duty? Is there an increase in absence and tardiness? Appearance is judging their overall look, meaning do they look disheveled and out of sync? It's vitally important to be aware of the signs and behaviors and to seek assistance once identified. If you suspect substance abuse, do not hesitate to take further actions, as it may be those actions that save a life. We'll talk briefly here about what to do when impairment occurs. This topic is covered in more detail in Module 5. Resources are also available online at www.aanapeerassistance.com. When impairment occurs at the workplace, it's important for healthcare facilities to have an action plan in place. If there is no policy in place, often colleagues do not know what to do when confronted by an impaired coworker. Therefore, it's important to understand what is and is not your role. Coworkers recognize the seriousness of the problem, yet some may cover for individuals or ignore the issues. It is not your job to confront the addict, but to report it to a supervisor for the proper intervention after fact gathering. Only trained addictionologists should provide an intervention of the addict, leading to controlled and protected environments for a period of time. Addiction is a treatable disease. These same criteria used for chronic disease models like diabetes or heart disease should also be applied when looking at and treating addiction. There are major tissue changes in the brain with addiction. Relapse is a part of the disease model and can occur during or even after successful treatment episodes due to neurological changes. Protracted abstinence and restored functioning is often a long-term, lifetime process requiring repeated treatments to recover from addiction. Lastly, participation is important in initially seeking out treatment, during, and following treatment. Participation is helpful in sustaining long-term recovery. Bench research in the neurobiology of addictions has demonstrated a physiologic and chemical susceptibility and change. Over the course of evolution, we have developed circuitry in our brains that has promoted and protected our survival. Basic neural pathways were typically developed in the following pattern. At first, there was a need for the basics in order to survive. The primal drive was to acquire and seek satisfaction of food and to promote the race of humans. As a result, procreation was made pleasurable. Dopamine is the neurotransmitter most responsible for pleasurable behaviors. As the pleasure of life replaces the need to survive, the dopamine levels rise, leading one to seek pleasure more frequently. As social networks became more civilized, the necessities and desires for satisfaction and pleasure were changed from survival to incorporate more pleasure. In order to seek pleasure, the levels of dopamine have to be increased. Neuroplasticity is a science that refers to the brain's ability to change with time and function depending upon the input to the brain. The introductions of modern conveniences have removed the need to survive. Therefore, other methods are found to increase the dopamine pleasure levels in the brain, causing a shift in how the brain responds. Neural pathways take some time to naturally change, given there is no change in the environment. With the introduction of chemicals and other external factors, the changes that cause addiction can be accelerated. Addiction is multifaceted and insidious. It changes the way one thinks by reprogramming neural pathways to seek only pleasure without regard for higher cognitive function. The addict suffers from craving for the drug. At this stage, only satisfying the pleasure pathways can help momentarily to alleviate the craving. The cycle continues, and in the last stages of addiction, survival is defined by drug-seeking behavior, which is an obsessive-compulsive behavior of trying to find and satisfy pleasure. Contemporary neuroscience has helped us elucidate how primitive midbrain reward processes effectively and persistently subvert higher cognitive functions such as decision-making. Once changes are made to the neural pathways, it is difficult, if not impossible, to change the pathways back to their original state. Therefore, when someone becomes addicted, there is a need to change the neural pathways to a more constructive behavior pattern by first removing the chemical and allowing the brain to readjust the levels of dopamine. In some instances, this change may require long-term medications and therapy. Dr. Stephen LaRoe informs us that the very primitive survival behaviors are sabotaged by chronic exposure to addictive substances, having many times the potency of natural rewards such as food, sex, or comfort. With constant exposure to drugs, and regardless of evolutionary status, Subjects will seek pleasure by self-administering some rewarding drugs in preference to food, water, rest, or sex until death results. Dr. Abraham Twersky describes the apparent subversion and distortion of higher cortical processes by this simple but profound example. This is the apparent change in frontal processing from a normal functioning logic to an addictive logical perspective. This also provides an insight into the changes that occur with neuroplasticity and other neurological diseases. The progression from normal to abnormal logical thinking can be viewed as normal. All trees have leaves. This object has leaves. This may be a tree. Neurotic. All trees have leaves. This object has leaves. This may be a tree. And when fall comes, I'm going to pick up each leaf as it falls. Psychotic. All trees have leaves. This object has leaves. Therefore, I am a tree. Addictive. All trees have leaves. This object has leaves. Therefore, I need a drink or drugs. To contrast organ disease, this PET scan by the National Institute of Drug Abuse demonstrates the effects on the brain during drug abuse with cocaine. There is a decreased metabolism in the brain. The same is seen in the patient with heart disease and the disruption of blood flow. Once these pathways become permanent, they become very difficult to change. Addiction is a developmental disease that typically begins in early childhood and is accentuated by genetics, environment, culture, and many other factors. Additional information on the science of addiction can be found on the National Institute of Drug Abuse website. See the link in the reference list. In the non-addicted brain, there are filters that allow one to make rational judgments and stop before a bad outcome. Addiction changes neuroplasticity and allows for detrimental behaviors. In the non-addicted brain, control mechanisms constantly assess the value of stimuli and the appropriateness of the planned response, applying inhibitory control as needed. In the addicted brain, this control circuit becomes impaired through drug abuse, losing much of its inhibitory power over the circuits that drive response to stimuli deemed salient. There are 4 common molecular changes that are associated with dependence. Dopamine is sent from the midbrain to the frontal cortex and plays a large role in addiction. Chemicals either increase the amount of dopamine or prevent the uptake or reabsorption of dopamine at the neural end. Cyclic adenosine monophosphate response element binding protein, or CREB, is a transcription factor that is changed by chemicals. CREB is decreased in nucleus accumbens and has an extended life in the amygdala during the development of dependence upon a chemical. The brain's reward circuitry is found in the nucleus accumbens and extended amygdala. The craving circuit, or the dorsal prefrontal cortex, is also in the basolateral amygdala. Glutamate is a neurotransmitter that regulates the release of dopamine from the frontal lobe to the central brain. Dopamine demands become larger with addiction, and new neural pathways are made. Glutamate becomes more passive, yielding to the dopamine and chemical pathway. Delta Phos-B transcription factor is changed during protracted abstinence to drugs of abuse, leading to craving. The compulsivity circuit is found in the ventral striatum, ventral pallidum, medial thalamic, and orbitofrontal cortical loop. The Pleasure Unwoven video produced by Dr. Kevin McCauley in the Institute of Addiction Study provides the latest neuroscientific research on addiction. This small segment shows a representation of how dopamine and glutamate interact and how addiction distorts the process.
Cortex.
For more information on the video and Dr. McCauley's research, visit www.pleasureunwoven.com.
Back down to the midbrain. As the brain generates an experience of pleasure, the neurons going up release dopamine. And the neurons going down release glutamate.
Normally, this up and down communication enables the brain to recognize and learn those things in the environment that are good for survival.
Dopamine says, hey, this is important. Glutamate says, okay, I'll remember. Dopamine says, hey, I really want this. Glutamate says, fine,
Go and get it.
That's the way this elegant but delicate system was meant to work. For food, for sex, for Madeline cookies.
Drugs go straight to this mechanism and wipe it out. These surges of neurochemicals are like flash floods tearing through the landscape of the brain. Each use of the drug, every flash flood, ravages the brain's delicate physiology, sweeping away everything in its path.
With time, deep channels are carved into the brain. Drug pathways become stronger and stronger. Normal pathways become weaker and weaker. Dr. Stephen Hyman of Harvard University calls addiction a pathological overlearning of the drug and all that goes with it. This isn't a normal memory. This is a drug hypermemory, and these memories may be permanent. They leave the addict vulnerable to relapse even after years of abstinence.
The natural neurologic and chemical reward systems are set up naturally in humans. As individuals, we each seek pleasure from food, sex, touch, etc. The distortion of this system can occur from a variety of causes and for a variety of reasons, but once restructured, become extremely difficult to change or permanent in action. In order for us to recognize and also be a part of someone's recovery, it is important to understand the depths of addiction. Addiction begins with the euphoric effects of potent chemicals on our primitive reward systems. These intoxicants underpin basic biological survival drives, which leads to the progressive and repetitive state known as addiction. Ultimately, maintenance of the addiction cycle is mediated by persistent neuroplasticity in the reward and anti-reward systems. Avoidance of the dysphoric states of withdrawal symptoms becomes the most powerful drivers of persistent addictive behavior. Recovery from addiction requires one to want to change. In the early transitions, denial is a relative common process in which the addict denies a problem at all. Once the addict is willing to change, then a long-guided process is initiated. Relapse is a normal occurrence of any disease process, and relapse in addiction is no different. Incentives for remaining in recovery include random urine and blood samples, potential legal implications, and loss of license in healthcare professionals. To transition from an addiction to a life without addiction requires removal of the sources and/or stimulus that produces a change. The agent that provides the pleasure stimulus has created a new neurological response that has to be changed. Changing the neurological tracks many times requires pharmacologic management with experienced addictionologists. Rewiring of the neural tracks and withdrawal from chemicals is many times very difficult for the addict. Constant behavioral therapy and support is part of the transition. In the neurobiological development of chemical dependence, Goodman illustrates that CRF is released from two different regions within the brain. Each of these regions function as separate but connected stress systems. According to Koob, the HPA axis, which is the mediator of hormonal stress response, activates CRF transmission within the neural pathways. Through the science of neurobiology, Koob and Lamole, 2008, explain the key elements of the motivational factors that produce change. Anti-reward systems are a construct based on the belief that brain systems are in place to limit reward. As dependence and addiction develop, brain stress systems such as CRF, norepinephrine, and dynorphin, a natural opiate, are recruited to obtain a feeling of pleasure based upon the shortage of natural chemical messaging. To improve that missing feeling of pleasure, other means are sought out to stimulate the pleasure feeling during addiction and in recovery. Dependence develops as a result of using chemicals, and these physiological changes also need to be treated. These systems produce aversive feelings and/or stress-like responsive states that become difficult to tolerate. At the same time, the stress states develop and motivational systems in the ventral striatum of the extended amygdala decrease. The combination of this decreasing reward system, no feelings of pleasure, with an increasing recruitment of anti-reward neurotransmitters provides a powerful source for negative reinforcement. These chemical changes are strong and actually contributes to the compulsivity of drug-seeking behavior and addiction. The stress hormone cycle is stimulated during the withdrawal of chemicals, which can lead to sympathetic overload. Withdrawal is a critical physiologic response that needs to be effectively treated because it may result in stroke, myocardial infarction, and/or other hypertensive complications. During withdrawal, patients have hallucinations and delirium, typically associated with the high levels of circulating epinephrine and other catecholamines. Mental health diseases occur when someone lacks the ability to manage day-to-day events and/or control their behavior, so that basic physical and emotional needs are threatened or unmet. The root causes are many times multifaceted, including genetic, biologic, and drug-related factors. Dependency on a substance or other addictive behavior is scary, destructive, and unpredictable. Substance use and dependency are diseases and can be successfully managed with appropriate intervention and treatment. Intervention focuses on increasing insight and awareness regarding substance use and motivation toward behavioral change. A goal of these 6 modules is to build awareness of these realities so that you can take the necessary steps to avoid choices that lead to addiction, as well to aid your colleagues who may have addiction issues. In turn, you are helping the anesthesia profession as a whole by reducing risky behavior that can lead to mistakes and/or job loss. According to Frank and Dingle, the lifetime comorbidity rates for affective mood disorders are as high as 38 to 44% in healthcare providers. When combined with chemical dependency, the rates and intensity of mood disorders increase. Emotional illness and substance abuse typically coincide. Frank and Dingle reported in 1999 the risk for suicide resulting from co-occurring depression in healthcare professionals. Mood swings are common with addicts, resulting in further misuse of drugs in an attempt to control the mood swings chemically. Emotional illness worsens the course of chemical misuse, and substance abuse worsens the course of emotional illness. Users frequently choose drugs that exacerbate their disease. Addiction can co-occur with depression, and suicide risk is very high in healthcare providers. They are also more successful in their suicide attempts than other professions compared to the general population. These addictions have characteristics similar to chemical dependency, including mood swings, obsessive-compulsive behaviors, and difficulty in changing behaviors. Addiction can manifest in a number of forms, and relapse can occur in a variety of disorders. Here are a few addictive disorders that may appear. Excessive overeating and undereating are behavioral disorders. Anorexia and bulimia is primarily found in females 90% of the time. Sex addicts usually are obsessed with sexual activity, including videos, photos, pornography websites, and performance. They will display increasing preoccupation with sexual activities. Shopping disorders often involve kleptomania. Preoccupied and excessive amounts of time involved in chat rooms, playing games, scanning websites, and online buying are all symptoms of addiction. Gambling is an underreported addiction. The criteria for gambling addiction includes preoccupation and increasing amounts of activity and bets. It is estimated that 3 to 7% of gamblers have problems, and 2 to 4% in Gamblers Anonymous are women. It's understood that women gamble to escape. Men gamble for the action. Suicide is high in gamblers because their addiction may bring greater shame upon the gambler because their addiction can directly affect loved ones in the form of losing one's house or life savings. Gambling is also associated with other addictions like drinking or issues such as depression. Depression often accompanies addiction. The use of alcohol, heroin, and other opiates frequently causes symptoms of depression and sometimes depressive illness. Alcohol, benzodiazepines, and cannabis often create anxiety disorders, while cocaine addiction can resemble or create bipolar mood swings. Typically, diagnosis of depression in an addict takes 4 to 8 weeks of clean time before substance-induced depression can be ruled out. Careful observation for depression and suicide is important for at least 8 weeks once all the chemicals are stopped. According to Chippas et al. In 2012, in 2010, 14% of nurse anesthesia students reported suicidal ideation within the previous year. Given the high level of stress and increased incidence of depression that they exhibit, this is a sign that must be heeded. A healthy lifestyle must be promoted to all of our students and providers. Healthy students lead to healthier practitioners. Depressive symptoms are highly prevalent among nurse anesthesia students. Nurse anesthesia education and training can directly contribute to the development of depression and behavioral problems such as alcohol and drug abuse. Time constraints placed on the student through work overload, competitive environment, constant pressure of assessment, as well as the difficulties of the coursework, expose the student to stress from the admissions process through graduation and taking of the board examination. Unfortunately, it is often difficult to distinguish depression from the effects of the stress inherent in student life. Society in general looks upon depression as a weakness, so many of our youngest and brightest must struggle in silence. There are solutions that can help students who suffer in silence. Moffitt et al. In 2005 found that medical students had a rate of clinical depression that was twice that of the general graduate student population. This comparison indicates 2010 data on student nurse anesthetists by Chippas et al., which found the rate of depression to be 11% higher than that of the medical students, and 5% higher than the previous study of nurse anesthesia students in 2008. Because depression is often not recognized, suicide is dreadfully successful in healthcare professionals. Suicide is a profound loss of life and professional talent and needs to be carefully considered and aggressively treated among healthcare addicts. Rate of suicide is disproportionately high for anesthesia providers, making them an at-risk group. Thoughts of suicide should be taken seriously. Those nurse anesthetists that are suspected of substance abuse and/or depression should be readily referred to treatment. 2/3 of anesthesiologist suicides are preceded by depression and alcohol and/or drug abuse. And herein lies the opportunity for us to step in so that colleagues can receive the help they need before depression becomes something worse. Student distress encountered during graduate studies may contribute to their cynicism and may negatively affect their personal and professional relationships, as well as impact the culture of the nurse anesthesia profession. The most troubling mental disorders include an increased incidence of drug and alcohol abuse. As has previously been shown, nurse anesthesia students may not cope with their increased stress in the most positive manner that promotes wellness. The major risk factors for suicide, mood, and substance abuse disorders often coexist, placing the nurse anesthesia student at particular risk in the absence of recognition and treatment. The Diagnostic and Statistical Manual of Mental Disorders suggests that 5 or more of the following symptoms in a 2-week period is a sign of depression. Depressed mood most of the day, nearly every day, is indicated by either a subjective report in which a person feels sad or empty, or an observation made by others in which a person appears tearful. Markedly diminished interest or pleasure in all or almost all activities most of the day. Nearly every day is indicated by either a subjective account or an observation made by others. Significant weight loss when not dieting, or weight gain, such as a change of more than 5% of body weight in a month, or a decrease or increase in appetite nearly every day. Insomnia or hypersomnia nearly every day. Psychomotor agitation or retardation nearly every day. This is something observable by others, not merely subjective feelings of restlessness or being slowed down. Fatigue or loss of energy nearly every day. Feelings of worthlessness or excessive or inappropriate guilt. diminished ability to think or concentrate, or indecisiveness nearly every day, either by a subjective account or as an observation made by others. Depression is often manifested in the form of poor concentration, loss of interest, and feelings of worthlessness, loss of pleasure, weeping, irritability, poor hygiene, and appetite. Drugs are often employed to help individuals with psychosomatic symptoms and sleep during treatment. Some common antidepressants are Prozac, which has a long half-life and is now generic, making it inexpensive. Luvox is now approved for OCD. Paxil has more anticholinergic effects. Zoloft has fewer drug-drug interactions, and Celexa and Lexapro are other options. One of the best solutions to depression is exercise. In 1989, Johnsgaard reported that 30 minutes of aerobic exercise 3 times a week will significantly reduce depression. The type of exercise doesn't seem to matter. While exercise is a good outlet, addicts must be cautioned that endorphins are released with exercise and can lead to an exercise addiction. Endorphins are associated with a runner's high or feelings of euphoria after exercise. This occurs because beta endorphins increase feelings of well-being for a period of time after the physical exercise has been discontinued. It's important to do what you can on your own to fight depression, but be sure to make others aware, especially your physician. In our final message, it is our hope that we have brought to your attention the signs, symptoms, pathophysiology, and comorbidities of substance abuse. Staggering nurse anesthetist substance abuse and suicide statistics implore us all to look for depression and other symptoms that can lead to chemical dependency and other disorders before they become workplace issues. Things like on-the-job stress, familiarity with various pharmacotherapy treatments, and access to various drugs are all factors that make substance abuse more prevalent in our profession. Chronicity and relapse potential can be explained by the changes in neural pathways that are created with chemical use. Treatment is multimodal, and new pharmacotherapy strategies may assist as part of a treatment regimen. Keep in mind, chemical dependency is similar to other diseases such as diabetes and hypertension when considering compliance and relapse issues. Our future depends on healthy, well-balanced people providing the proper care to patients, which is why this new approach is needed to increase focus on education and relapse prevention.
We hope the content from the Wellness and Chemical Dependency in the Nurse Anesthesia Profession curriculum modules will help each of you care for yourself as well as your patients. When you complete the curriculum, you'll find an increased knowledge of the occupational risk of chemical dependency in anesthesia professionals. The curriculum is designed to encourage you to build the ability to cope with stressors and to recognize the signs and behavior of an impaired colleague, as well as resources to find the available peer assistance when needed. The AANA provides supportive and supplementary information to this curriculum online. Go to www.aanawellness.com and follow the link for wellness, education, and research.